these. All right, so this is case 1. This first image is the HND. It's your invasive carcinoma of no special type, ductal. The second image is at power 20, and then the last image is at power 40. So would you call this a 0, a 1+, 2+, or 3+? Okay, we'll move to the second case. Also an invasive carcinoma of no special type. Are you calling this a 0, 1, 2, 3, or 4? This is case 3. And this is the last case, case 4. Okay, so we'll come back to these at the end of the presentation. So just to recap from Prof. Syed's presentation, HER2, as we know, is a tyrosine kinase receptor. It's a member of the epidermal growth factor receptor family. And basically, it works through homo and heterodimerization with EGFR family members to initiate cell signaling through phosphorylation and then multiple downstream signaling pathways, which ultimately result in cell cycle, progression, proliferation, and breast tumorigenesis, okay? So overexpression or amplification will promote tumor cell survival and proliferation. Now, when it comes to assessing HER2, we can do so either via IHC, immunohistochemistry, or via in situ hybridization. The difference between the two being that IHC will provide a semi-quantitative result, so basically the amount of HER2 that is expressed by the tumor cells, okay? This is in contrast to in situ hybridization, which will detect the number of HER2 gene copies within cancer cells. Now, these tests are not used in lieu of each other. It's not that if IHC is not available, then you go ahead and do ISH or vice versa. No. The guidelines are very specific. You start off with IHC, and then depending upon the result that you get, you go on to do in situ hybridization. So when it comes to interpreting HER2 IHC, the way I like to think about it is through 4 key questions. Number 1, is there staining or not? Okay, so if there's no staining, that's an obvious 0. But if there is staining, then the next question you need to ask yourself is it membranous or cytoplasmic? Yeah, I want us to take note of the fact that cytoplasmic staining is not uncommon with HER2 immunohistochemistry and should be disregarded in the scoring, okay? We only take into account a membranous staining pattern. So once we've established that there is membranous staining, is it incomplete or complete? What is the staining intensity? Is it faint, moderate, or intense? And what is the percent of tumor that is staining? So at current, we use a 10% cutoff. And that allows us to be able to ascribe a score, okay? So either 0, 1+, which is also known as HER2 low, equivocal, or 2+, and 3+. And we'll go through each one of these briefly. So we'll start with score 0. Remember, the first question we're asking ourselves is there staining or not? So if there's no staining, you automatically ascribe a score of 0. However, if there is staining and it is membranous, incomplete, but faint and barely perceptible in less than 10% of tumor cells, then you would ascribe a score of 0. And practically under the microscope, this is how it would look. So again, we have our HND image at power 20, HER2 at power 20, where we can clearly see that there's no staining, and then at power 40, where there's no staining. So this would be an obvious 0. I wanted to project this image because at power 20, you might be inclined to think this is a score 1+, However, when we go to higher power at power 40, you notice that quite a bit of this is cytoplasmic blush. Remember, we disregard cytoplasmic blush when it comes to HER2 scoring and only use membranous, okay? So in that particular image, only less than 10% show incomplete membranous staining, and so you would score this as a 0. The second score we can ascribe is a negative score 1+, or what is now known as HER2 low, okay? And this basically means that there is staining, it is incomplete, it's faint and barely perceptible, but unlike ultra low or score 0, where it's less than 10%, here more than 10% of the tumor cells are positive, okay? And practically that would look as such under the microscope. So remember, always disregard cytoplasmic blush, only take into account your membranous staining. Then we have HER2 equivocal, or score 2+, which as per the current guidelines, it is recommended that should you get such a score, you go ahead and do reflex-ish testing, which will be the next presentation after this, which enables us to classify these tumors as being either non-amplified, so HER2 low, or amplified, which will be managed as positive, okay? Under the microscope, these tumors will show complete membranous staining that is weak to moderate, but in more than 10% of the tumor cells. The difference between this and score 3 being that with score 3, the staining is intense, it is complete, and again, in more than 10% of tumor cells. So it sounds very simple in theory, but we all practice, so we know that we will occasionally encounter borderline challenging cases. So I'm just curious from the group, how would you score this first case? Anyone? You'd go 2+ on this. And the second one? So 2+ for both of them. So when you encounter these borderline challenging cases, it's important to always go back to the algorithm. So is there staining? Yes. Is it membranous? Yes. Is it complete or incomplete? We'll start with the first one. So there's a couple of cells that do show complete staining, but for the most part, it's incomplete, right? It's in more than 10% of the tumor cells, right? So we definitely know it's not a score 0 or ultra low, right? And it's pretty faint, so this would be a score 1+. Yeah? You don't look convinced. Now, for the second case, again, back to the algorithm, we do have staining. It is membranous. It is complete. Yeah, it's weak to moderate in more than 10%, and so this would be your classic equivocal case, okay? So all that just to stress that should you encounter a borderline case, always go back to that particular algorithm. Now, we can have false positive immunohistochemistry with HER2 staining. The commonest would be cytoplasmic positivity. Just to reiterate, we do not consider cytoplasmic blush when we are scoring HER2. Another cause of false positive results would be your edge artifact, and this particularly tends to be seen with core biopsies where the cells near the edges will stain stronger because the antibody is pulling, okay? It's important to interpret such cases with caution. Overstaining can also occur. Please note that you can have benign breast tissue staining for HER2. but it should be faint, barely perceptible, and only basolateral. If you're looking at a slide and your benign breast shows strong membranous staining, you should repeat before interpreting that slide. Okay, and then the final one is misinterpretation of DCIS as invasive carcinoma, which can lead to false positive results. And this is just an image depicting what it would look like under the microscope. False negative results are not very common, but they can occur. They'll typically be due to prolonged cold ischemia time. We know that we should limit this to 1 hour. Maybe due to tumor heterogeneity. So the CAP guidelines actually state that if you have a negative HER2 score on core biopsy, but the morphologic features are not quite in keeping, so you're looking at a very high-grade lesion with a high proliferative index that's ER/PR negative, then repeat testing on the subsequent specimen is recommended. Okay, and then the final reason you can have a false negative result is because your antibody concentration is too low. So in that case, then you would have to reconstitute. There are artifacts that we do need to be aware of when it comes to assessing HER2. The first is retraction artifact, which will result in staining along the open spaces, okay? So remember, staining along the open spaces should not be included in your final HER2 scoring, not unless that staining is also present extending along the tumor cell membrane, okay? Non-specific staining can also occur. So on this particular image, if you adjust to assess at power 20, you might be inclined to call this a 1+, right? But when we go down to higher power, you notice that there's quite a bit of background staining as well as cytoplasmic staining, okay? So this is likely due to poor fixation, and the recommendation is to repeat on another block or sample. Crash artifact can also occur, which would result in quite a bit of non-specific background staining. And again, just to reiterate for the final time, cytoplasmic and nuclear staining should be disregarded when it comes to scoring HER2. So this is not a 3+ case, okay? You would have to repeat in such a case. So in summary, always go back to the 4 questions. Is there staining? Yes or no? Is the staining membranous or not? If it is membranous, is it complete or incomplete? What is the intensity? And what is the percentage of tumor cells that are staining? So there has been no change in the latest ASCO-CAP scoring algorithm. It was updated last year, but now there is emphasis on reporting -1+ or HER2 low from 0. Okay. As we mentioned at the beginning, reflex testing should be performed for all HER2 equivocal cases using an FDA-approved ISH test, and it's important to exclude DCIS, artifacts, as well as normal tissue in your overall scoring. So we'll come back to where we began. So case 1. What score would you ascribe this? So there is membranous staining. It's complete. It's weak to moderate. Actually, it's strong. And in more than 10%. 3+, right? Okay. We'll go to the next one. Anyone? 2+, yeah. This would definitely be an equivocal case, so you would go ahead and do in situ hybridization on it. Case 3. Zero, correct, yeah. So there's quite a bit of cytoplasmic blush, and we disregard that in scoring. And then the last one. A 1+, correct, yeah. So, what is the importance of identifying HER2 low? In Prof. Syed's presentation, she mentioned that 20% of all breast cancers are HER2 positive. And in our setup, in a similar study done by Syed et al., we found that 7.7% of our breast cancers are HER2 positive. So still quite a significant number. And prior to management with HER2-targeted therapy, these patients tend to perform very poorly with regard to overall survival, as is depicted by the red arrow, okay? And so because of this, for unresectable or metastatic HER2-positive breast cancer cases, there's been quite a bit of research with regard to drug development, and that led to the development of monoclonal antibody trastuzumab in 1998 and then pertuzumab in 2012. And these drugs were found to inhibit tumor cell growth by acting synergistically with chemotherapy, thereby stimulating, and as well as stimulating the immune system to target tumor cells. And once we discovered these drugs, there was a marked change in how these patients performed, okay? So the graph on the right shows you their survival prior to the introduction of trastuzumab, with the graph on the right showing you their overall survival, which improved from 20.3 to 25 months. But despite that success, there was a subset of patients who still failed to respond or experienced disease recurrence even when on trastuzumab, okay? And so that led to the development of the first antibody drug conjugate, trastuzumab emtansine, or TDM1, okay? So this worked different from the monoclonal antibodies, basically delivering chemotherapy drugs specifically to cells expressing the HER2 protein. And so again, we had a bit of success, but this particular drug demonstrated poor efficacy in patients with heterogeneous disease. And not only that, but we began to think at that point, what about the 80% who are considered HER2 negative, who were not candidates for anti-HER2 therapy and who had a poor prognosis when standard endocrine or chemotherapy was no longer effective? So that's this category of patients. So enter the Destiny trial, okay, where the aim was basically to evaluate the use of TDXD in HER2 low, as well as metastatic breast cancer that was refractory to TDM1, okay? Now, in these trials, they assessed HER2 expression using the Roche 4B5 assay and classified HER2 based on the scoring system that we have just gone through in order to determine patients who would be eligible for the trial. Ultimately, they found that TDXD had clinical benefit in patients who were classified as HER2 low or negative score 1+. And so this graph just depicts the overall survival, progression-free survival in patients who are hormone receptor positive, HER2 low, the blue line showing that they did have a marked survival benefit when managed with TDXD. And the same applied when all patients were taken into account, okay? So that's also including your hormone receptor negative, HER2 low patients. There were major safety concerns with this particular drug, and that is interstitial lung disease and pneumonitis. And another key point to note is that patients with HER2 expression less than 1+, okay, that is your ultra low, were not included in the clinical trial and so are not eligible for management with TDXD, okay? The Destiny trial 6 is currently investigating those patients, so we might see something new with regards to their treatment. And so currently we classify HER2 as being positive or negative, but following the findings of the DESTINY-4 trial, right, it's likely that we will make the shift to what is depicted on the left, okay? So HER2 positive, that's a 3+. Hormone receptor positive, HER2 low, okay? Hormone receptor negative, HER2 low, which actually accounts for majority of the breast cancers, and your triple negatives. So this is how we started, right? We started with our monoclonal antibodies, that's trastuzumab, pertuzumab, but there was a subset of patients who did not respond, and so we went ahead and we developed our first antibody drug conjugates, that's TDM1, but it wasn't effective for heterogeneous disease or HER2 low patients, and so now we're currently at TDXD. Okay? So just to stress, scoring is important. It's very important because there are downstream effects as to how these patients are managed. Thank you. Any questions?
Amelia, are you there?
Yes, I'm there. I just didn't hear you.
Oh, sorry, my mic was off. So I'm going to unshare. I think I'm going to close this presentation and then you can... Oh, there you are. Okay, you can go ahead.
Okay, I will. to the pathologist to adhere to clinical guidelines of how to interpret things. And maybe if you're up to 90%, that's because you really feel that you want to send everything to ISH and you don't trust the IOC. The mean rate should be around 23% if we look at the whole results from all pathology labs. But there have also been shown multiple times that we're not very poor, but the concordance in results, depending on if you go with a central testing and reference lab that has a lot of experience, and if you compare that to local testing that has just a few cases and doesn't get that much experience, then the concordance isn't great. And these studies was done on fish, so you can see 88% for fish and even less actually for IHC. And then, of course, there is this genetic heterogeneity that is just a biological feature, and that complicates the HER2 status assessment, both for immunochemical states and for cytohybridization. And it has been described to be seen in 11 to 40% of breast cancer, and I think this study actually refers to the upper range. We have noticed that the heterogeneity is even more prominent in the low, HER2 low situation. So all this to say that following the guidelines and being well aware of how we should score cases can address a lot of these issues. And if I go back to this study, let me see. Now you see this study that I talked about before. Their conclusion from this one was that everyone needs to be retrained, and that's exactly what was done, so that they understood how to score, even if they've been scoring HER2 for 30 years. And we are waiting now to see the follow-up study if this different rates of positivity has changed after the training. So let's go then into the guidelines of how do we score in cytohybridization. And this is based on, first of all, the interpretation guide that you can find from Ventana and Roche, but also we will talk about the clinical guidelines from ASCO-CAP. But the basic remains the same. We need to go through these 4 steps. We need to check for normal internal controls. That's true for both bright field and fluorescent-ish. And then we need to be very, very careful that we count in invasive carcinoma cells. So it might be needed to go back to the H&E to really identify those areas and try to keep out of in situ areas, also excluding stromal cells that can be also inflammatory cells, because in both bright field ions in cytohybridization and in fluorescence, you really see more of the nuclei. You don't have the full cell morphology, and that might make it a little bit difficult, especially when you're in high power, to differentiate an invasive tumor cell from another cell where you shouldn't count. So the selection of cells is very important. And then we go to the more practical points of just counting the HER2 signals and the chromosome 17 signals. We always need to have these 2, and that's also what ASCO-CAP says, that we should use dual staining if available. And some labs still have single inside hybridizations, and then they need to compare for 2 different slides, the HER2 and the chromosome 17. But then, of course, that becomes a little bit more, it comes with a lot more variation, because you can't really identify the same cells on these 2 different slides. And then it's just to go to calculation. The basic requirement is that if you're in the borderline situation and that the ratio ends up between 1.8 to 2.2, you should count at least an additional cells. I would also like to just later address this a little bit further, because that's really the basic requirement. And several studies have shown that if you're in borderline, count more cells, up to 80, 120 cells, because that will reduce this just clear signal. So you can see in the first one you have appropriate internal controls here in the fibroblast, and in this one that didn't pass the first control, you can see that you have signals in the tumor cells, but you lose them first in the fibroblasts. So make sure that you have in those cells that are not supposed to have a lot of signals. If they're there, then you're good to go. And then identifying the invasive carcinoma. So here's really where the morphological context plays a huge role. So if we look at this H&E here, you can see in A, we have an area of in situ carcinoma, and here in B, we have the invasive component. And then we have just the same low power field of the in situ hybridization. If we look closer then into this in situ area, you can see a lot of HER2 signals depicted in black. So we see clusters of HER2 gene copies. But if we go to the invasive area, we see that there is actually a normal number of the black HER2 and the chromosome 17. And that's quite common to see. And it's also common to see that in HER2 IHC that the in situ can be a 2+ or 3+, and the invasive is much less. But it's the invasive component that we want to treat, and that's why we should always make sure that we keep our scoring into the invasive part of the tumor. In addition of just identifying the area of the tumor where we should do the scoring, we also need to select the cells. And there's a few things to think about when we select the cells. And here is where the heterogeneity of the tumor comes into play, because you can see when you go into the slide and you see that different amount of signals in the tumor cells, then, I mean, and you're only supposed to count 20 or 40 or 60. So how do you select them? Do you do a little bit of a cherry picking and pick the ones with the most signals? And how do you avoid to just include lymphocytes or something in between? So that's why these recommendations have been put to try to cover all these different questions. First of all, you should count the nuclei with the highest average number of signals, and especially HER2. And then you should be really careful to count the representative size. And this sentence is really to make sure that you're not including fibroblasts or lymphocytes or something else that might be a little bit smaller. So try to identify the size of the tumor in a low power, where you can see that this, from morphology, that this is really an invasive component. And then you see that pick cells that look similar, so that you keep to invasive tumor cells. And also because of the sectioning, so that you don't end up in a small cell that might just be like the upper top of a cell, and you really don't see the number of signals that should be in the center. But in addition, we have this heterogeneity, and it can be different types of heterogeneity. You can have these clustered populations of HER2 positive tumor cells, and you can also have it mixed with non-amplified. And that's why we have this select the highest average number, because we want to capture heterogeneous cases, because they can also benefit from treatment. And if this heterogeneous subpopulation is more than 10% from clinical information, we think that they can benefit enough. If it's less, it becomes both harder to identify them, and we know less about how they behave on treatment. It's very important to report if you have a heterogeneous case that it is heterogeneous, because if you apply an anti-HER2 therapy in these cases, you might eradicate just that population that is HER2 amplified, and leave the patient with those that are not HER2 amplified. So that means that the oncologist might benefit from having this information, so that they can add more therapies, combinations of therapies, depending on if this is also endocrine positive, like it looks cluster case here on the right, and you can see that you have more of the HER2 copies in these cells that also present more of the protein. So just to illustrate for heterogeneous cases. So reiterating, highest average number of signals, pick those cells where you see that you have a high number of signals, and make sure that you keep out of the smaller or much bigger sizes. And yeah, and then of course, if you have a very weak signal, or if you have overlapping nuclei, or if you have necrotic areas, these are not the areas that you should select for counting. Sometimes we can also have excessive background that interferes with your ability to count the cells. And the most typical samples would be that we have a non-specific red signal. And here you can see red signals that are even sometimes outside of the tumor cells. And it just makes it hard to see what is a true red signal versus what is just a non-specific red signal. And sometimes it can also be that we have a high background of silver dust, and then that can obscure. Maybe here we can't see that these two are true HER2 signals, but this does make it really difficult. Maybe in this cell, is this a signal or if it's just dust? So keep out of those areas. If you have other areas that are without the silver dust, you can select those if you feel that they are representative of the tumor. Otherwise, it's really a restain that is required. Step number 3 of just counting is rather straightforward, and I mentioned it before. You really just count the number of signals of each black and red. So black in HER2 and chromosome 17 in red. And they should be inside the cell, so nothing outside of the nuclei. They can be of different sizes. The red can sometimes appear quite big. It should still be counted as just one signal. There is one caveat with the HER2 signal, is that sometimes there is a technical, it's a technical feature of the HER2 labeling that sometimes you can have something that's called a doublet, and then it should be counted as one signal. If you just have two HER2 signals that are so close to each other that the distance between them is smaller than the size of the signal. But personally, I just try to avoid those cells altogether, because if you have 3 signals, then it's a cluster already, and you have plenty of tumor cells in a slide. So, but you should be aware that that might happen, that you have doublets. Of course, if you have overlapping nuclei, don't count it. And if you miss one of the signals in one cell, don't count that one. And of course, if you don't have any signals at all. I wanted to speak a little bit about clusters, because clusters essentially means that it makes it very hard to count. And then there are some guidelines of how to address this. And the general guidelines is really just try to estimate how many signals you have in a cluster, and do that by comparing the size of the cluster to the size of a single signal. And then you can try to see, okay, how many do fit in a small cluster, and here's a big cluster, so maybe you can fit in 12 signals into that one, and then you just count it. But it's really just an estimate that where you do as good as possible. And usually in clustered situations, those are clearly amplified. So you might not need to go into that detail unless you're in a research study where you really want to discriminate between a highly amplified or a moderately amplified, and maybe in the future we will need to do that, because there are data out there telling us that depending on if you have a very high amplification or a moderate amplification or a low amplification, these patients don't respond equally to anti-HER2 therapies. One thing that is important to know is that if you have clusters, they might obscure the red signal. So sometimes you might need to go up very high in magnification just to try to see that red signal underneath. Otherwise, you can always count another cell as well. So here's an example of one cell that is very easy gives us a mean copy number of 3 in this case. And you do the same for chromosome 17, so you have a total of 33 signals of chromosome 17 in 20 cells. We don't care really about the mean copy number of chromosome 17, but we want to make a ratio between the 60 and 33 to have HER2 over chromosome 17 to see if we have a ratio that is more or less than 2, essentially. And in this case, we ended up with slightly below 2, so 1.8 if we divide 60 by 33. So now we have the information. What is the ratio? What is the mean copy number? And then we can assign a group. So the ratio per se tells us that this is less than 2, so it's considered negative. And the HER2 copy number tells us that this is group 5, which is, you know, the most negative case we can be in. And then we also we should report together with the ISH. We should always report the original IHC score, and we should have confirmed that score. So we should always look at the IHC together with the ISH, so to confirming the IHC score, but also to help us selecting the areas where we do the ISH assessment. There is a scoring sheet available in the package insert if you want to do this manually, just to help you to count the cells. In addition, it's good practice to report if you see clusters or not. Okay, so let's now go to the clinical guidelines. And as I said in 2018, these are the guidelines that we adhere to. They haven't been updated since 2018. CAP only sent out this emphasis on discriminating IHC 0 from 1 plus into 2023, but the scoring for ISH remains the same. And you can see the evolution here of what is considered negative and what is considered positive and what is considered equivocal, so borderline. And the focus in 2018 was really to try to reduce those numbers of equivocal cases where we couldn't say negative or positive clearly. And they also, what it did to do that was really to emphasize on the HER2 gene copy numbers. So not only the ratio that we needed before here, and the copy number was only, you know, between 4 and 6. Now really more into different situations to capture equivocal groups. These recommendations are really based on real-world evidence that I will show you later. But what it resulted is that we now are dealing with what we call the CAP groups 1 to 5. So this group number 1, that's and group number 5, these are the ones that we had from before, and then these 3 in the middle are the equivocal group. So group number 1, that's a clearly positive, and that means that you have a ratio that is more than 2, and you have an elevated number of HER2 copy numbers, so more than 4, then you're clearly in the positive amplified situation. And as well as for group 5, you have a ratio that is less than 2, and you have HER2 copy numbers less than 4, so really not many copy numbers, and you're clearly in the negative status. For the mid group, you can come from either having a ratio that is more than 2 or a ratio that is less than 2, and they will end up a little bit differently. If you have a ratio that is more than 2, but you have very, very few HER2 copy numbers, so less than 4, that situation you will only arrive to if you have if you have very, very few chromosome 17. And we call this group number 2, and I will tell you later how we deal with them with regards to treatment. And say for if you have a ratio that is less than 2, but you have an elevated number of copy numbers of HER2, then we separate those into group 3 and group 4, depending if it's very much elevated, more than 6 HER2 copy numbers, or if it's borderline, you have slightly elevated. The main point is that for all these 3 groups, you really just can't report it. What you need to do is you have to do an additional workup. And the first step in that workup is really to go back to the immunohistochemistry re-evaluate. Is this really a 2+, or was it honestly more of a 1+? That you were just too scared to call it 1+, so you called it a 2+. Or maybe it was even a 3+, but maybe on the little bit of a weaker side, but according to definitions and you could actually call it a 3+. If you do that, then, and you call it a 3+, you are free to just call it positive. You're in an equivocal situation of HER2-ish, group 2, 3, or 4, but the IHC is the driving decision factor here, because it has a lot of target on the surface, and it's considered that these patients should benefit from being treated. So call that positive and don't bother about doing all this extra counting. And same as for the negative. If you don't have the protein expression and you're in this borderline, just call it negative. There's no point. There are other treatments that we can give these patients. Or you probably rather call it HER2 low today, because if you're in the 1+ situation. But if you still think, no, this is an IHC 2+, you should count at least 20 cells yourself, then you should ask your colleague to count also 20 cells. And if your colleague ends up in the same group as you did, then you have enough data points. You've been counting. You first counted 40 cells. Your colleague probably also counted 40 cells, but that's what you should do when you are close to a ratio of 2. Then you have data of 80 cells, so that's quite solid. Many things it's not solid enough, but it's relatively statistically solid. And then you should call the group 2, you should call it negative with a comment, and group 4 you should call negative with a comment, and the group 3 you should call it straight off positive. If you don't agree at all on the group, the recommendation is that you find an internal procedure, and the most common internal procedure is that you sit down together to do it. But I think it's also perfectly acceptable if you have access to digital algorithms or something else to help you to do it. What you do tell them also is that it's not recommended that you go with another test. So if you're doing the dual-ish, it will not help to just do a FISH instead. It's really more about understanding the individual tumor than just trusting different assays. Because there are, from a biological reasons, samples that will fall in this equivocal groups. And instead of just by chance doing another FISH or something else, putting them in one group or another, we should trust the data, and we should trust the information from clinical studies and real-world data. And what we know for the group number 2, where you have, even if you have a ratio that is more than 2, but you have very, very few copy numbers of HER2, they have been included in clinical trials. And we know in deeper data analysis that they don't have benefit from anti-HER2 treatment. So that's why we consider them negative. They should have something else. And if in this situation, where the ratio is less than 2, you have this slightly elevated HER2 copy numbers, these are the ones where we call true borderline cases, because they were based on the low ratio, not included in clinical trials, and we really simply don't know if they benefit enough to be treated. So I always feel a little bit sad when I end up with a group 4, because it's really where we lack insight of how these patients behave. But on the other hand, it's now other treatments that have shown effect in those, such as trastuzumab deruxtecan, if you have a 2+, and that might be a much better choice than just going with a simple HER2-targeted antibody. This group number 3 is a special case, because here you end up with a low ratio just because you have too many of the chromosome 17. So it's a true amplification of HER2, but it's being masked in the ratio just by the co-amplification of chromosome 17. So you have many HER2 signals, the black signals, but you have equally many chromosome 17 signals. So, and that's where the HER2 copy number is really important to drive us to understanding that this is a true amplification. So just a recap of the different groups and how we should report them: positive, negative, positive, and the two negatives, and this is the true borderline group. When it comes to clusters, so this was another internal study that we made where we asked 7 pathologists. These are international pathologists from different countries, and many of them involved in writing the clinical guidelines and research. So they're very, very experienced in HER2-ish interpretation. And we asked them to score the same cases on a digitalized, so on a screen, so they all saw the same cases, and we asked them to give us their scores. And you can see that when we had, these are the HER2 copy numbers results that we were looking at right here, and in those where we have very low numbers, you can see it's rather straightforward to count, and they were all agreeing to a level where it is acceptable. You can see there are differences, but the group where they assigned the case was all the same. And the same for the amplified, and these are mostly amplified with clustered cases. You can see that if you have a HER2 copy number between 10 and 15, or above 6, which is the cutoff of, then you can see that some pathologists, they tend to think that they can fit more signals into a cluster, and some think that they can't. But it really doesn't matter. They all report these as amplified cases, and the patient will receive the same treatment regardless of who is looking at it. But in these borderline cases, where we only have slightly elevated HER2 copy numbers, so between 4 and 6, you can see that even the real experts, some will end up calling this an amplified, some will end up calling this an equivocal, and depending on the ratio, it might be a group 2, 3, or 4, and a few will call them negative. And that's why I think it's so important that we not just trust how experienced am I or how experienced is my colleague, but we really try to build the data that we base that information on by just increasing the number of cells. That's the most mathematical and statistically secure way to do that. And here's a study showing that if we count more cells, then we reduce this margin of error that is applicable to any field that uses quantification. And they say that if you increase the cell count from 20 to 60 invasive cells, then it leads to stabilize this coefficient variant. And in some areas, if you really want to reach a margin of error that is 0.1, then you might need to count several hundreds of cells, which is, I mean, not necessarily needed, but from a mathematical standpoint of just achieving the same numbers, that's how high we need to go. In practice, that only means that 60 or 80 is very good, and I've seen several national guidelines that state that in borderline cases, you should count a minimum of 80 cells, is what I've seen, but here they show that 60 might be also good. I wanted to show you some examples before we end, and of just to increase your image bank of what the dual-ish looks like. So this is a typical example of a non-amplified. We can see it already from a low power that we have equal numbers, in general 2 to maybe 3 HER2 copy numbers per cell, and the equivalent 1 to 2 chromosome 17. So not amplified, you can see it already in the low power. Also here, the vice versa situation, you can see from a relatively low power that this is an amplified case. We have the clusters, and many of these cases are also 3+. So always start with the low power to just give your perception. I think in many cases, you will stick with your first impression of a non-amplified or an amplified, and it's really only a few cases where you will need to go to very, very detailed and extensive counting. So here's 2 other examples of non-amplified cases, but also just to show you that the pre-analytics and the protocol might affect the morphology. So to show a slightly increased number of HER2 gene copies. So now we're starting to come into the situation where we really want to start counting. So for instance, in this cell, we should count 1, 2, 3, 4, 5 over 2. Now we select this cell as well. And remember the guidelines, don't select sizes of cells that are smaller than the average size, and don't select cells where you only have one of the two signals you're expecting. So in this one, we only see the HER2, but we don't see chromosome 17. Don't pick one of those cells. Stay to this one, and probably this one, and then go to another field, because this has too few. You're also required to select cells with the highest average number of signals. So I would just pick a few that are really representative and then move on to the next field of view. And always go up and down in the magnification so that you make sure you stay in invasive areas of invasive tumor. Here you see one of these examples where we have elevated. It looks like, yeah, this could very well be amplified, but we also have an increased number of chromosome 17, and you can see in this one we have 1, 2, 3, 4, 5, 6, 7, 8 chromosome 17. This is a case where you need to count a lot of cells, in this case we actually end up with a very low ratio. And we have a slightly average copy number of HER2 of 5.2. If this would have been more than 6, we would have called it a true amplified case masked by co-amplification, but we couldn't come above 6 in average in this case. This is a group 4, which is a true borderline, not quite making it for amplified. Clearly amplified with small clusters, and we don't see a busy chromosome 17. You can see that the normal cells here in the background, they are acceptable because we see the HER2 and the chromosome 17. And then there are always some scattered cells where you will not have it. And that's normal, because if you only have a few signals, then depending on the plane of the section, you might miss some signals, but you should have it in the majority of the normally internal controls. Another example of amplified with clusters, here you can see both these clusters and much smaller clusters. So of course, depending on which cells you end up with, you will end up with very different HER2 copy average numbers, but for the sake of the patient, it will not have an impact on the treatment. Another beautiful example of a clustered amplified case with perfectly internal controls. And one more thing about internal quality controls is that if you have a clustered case and you would have unacceptable internal controls, it would still be positive. It's usually more in the cases where you have just slightly elevated number of signals in the invasive tumor, and you would have, if you would miss these signals in the internal controls, then you really can't trust it. But if you clear-cut amplified, even if this would have been negative, it would have been acceptable to report it. Here's some background, but we have very clear contrast to the signals, so it's still acceptable. But this one, where we have the silver dust, is not acceptable, because this area, it really makes it difficult to count it. As well as the cis speckling that sometimes also happens, and you just have a lot of black signals all over the slide, and you can't tell which one is belonging to the tumor cell and which one is just speckling. Here's one other example, what I was referring to earlier. You have these small clusters in the invasive tumor, but you can see all the negative internal control cells. There's completely missing signals. What that tells us is that we probably should have had more signals in the invasive tumor. If these lost their signals, then these have lost as well. So if this would have made it to a clearly amplified, I would still have called it amplified, but if I end up in a borderline case, I would restate, because I expect the number of signals here being much less than what they actually should be. And there have been patient malpractice cases where pathologists didn't pay attention to the internal control cells and reported it as negative, and especially if you have like a bone metastasis or something that has been treated maybe with decalcification, and then the patient presents with the metastasis somewhere else, like in the liver, and then you can see it's clearly amplified. So be very careful with those cases if you're in a non-amplified result situation. So these are the take-home messages. Really, you should follow national guidelines, or if you don't have the national guidelines, follow ASCO-CAP. They are very, very rigorous, and as healthcare professionals, that's what we apply to. The package insert guidelines are very good for the method of how to count, but remember that they were put out there based on limited number of studies, and they have been improved with the national guidelines. So the guidelines always continuously improve so that we can treat our patients better. Really, really important is to always score IHC and ISH together. They should not be separated. If you receive from another lab to do ISH, always request to get either the block to be able to do an IHC yourself, or ask to send the initial IHC slide together with the slide for ISH. So because you need to, first of all, confirm that the IHC score, and you also need to select the areas with most protein expression so that you can capture heterogeneous cases as well that might be amplified. Use the dual-ish so that you have chromosome 17 and the HER2 gene on the same slide. That really eases the evaluation and is needed for proper scoring. And morphological context is key, because you need to go to the invasive tumor component. You need to avoid inflammatory cells and fibroblasts and in situ components as well. And really, this one I think is also important, that borderline cases, they should be reviewed by another pathologist or together with another pathologist, and that is much, much better than just sending for retest. So if you end up, don't send it for FISH or another test, count more cells. That's statistically much more reliable than retesting. That's what I had, and I'm happy to take questions or comments, and I'll stop sharing so I can stop sharing so that I can see you.
Thank you very much, Dr. Mia.
Did I stop sharing?
No,
Yes.
you still share. On the top of the screen there is a red sign. If you go in the Zoom window, on the top, in the middle of the top.
We can't see your screen, so it's okay.
Okay. I don't see that one. But I see now you now. So
Yeah, so you are okay. So thank you very much for that excellent overview of HER2 staining. Are there any questions online? I can't see. Any questions online? Any questions from here? Everyone's tired. It's been a long
I don't hear you very well anymore. It's very
Can you hear me now?
sound.
Can you hear me?
A little bit better.
Okay.
I think you need to raise it.
Okay, so thank you very much. There are no questions in the room here. Are there any online questions? I don't think there are any online questions. So that's fine then. We shall break. Yes, there's one question.
I wanted to go back on counting on how we count the clusters and the protein and how we can get the HER2 copy number.
Okay. So the question, Emilia, is if you have clusters, do you count them as 8 signals or 6 signals, because it may be difficult to count each signal separately when they are in a very, like a large cluster or a small cluster. So there's a clarification required.
Yes, and I think usually do, and what we did at the breast cancer center where I worked, was that if it was big clusters, we just reported this as clustered and amplified, and we didn't count at all. We just paid attention to it. There was a lot of chromosome 17 signals that would require us to count. If it wasn't, if it just said clustered, amplified, positive, and cases closed. But in some, if we have very small clusters, then and you have more chromosome 17, so the slide is very busy with both red and black, then we try to count. And it's really about this, just estimating how many HER2 signals can I fit into a cluster. I do that once, and then I say, okay, I fit 8 into this one, and then I just give 8 to every cluster of that equal size. And then if the cluster is much bigger, yeah, then I might add on. But it's an estimation, really.
Thank you very much. Yes, I think that question's answered, yeah. So it depends on the size of the cluster. Large cluster, you might just say clustered, amplified. Yeah. Any other question? Any question for Dr. Priscilla?
I had one for Dr. Priscilla. I wanted to ask, so currently, what is the standard way of reporting HER2? Do we report 0, +1, +2, 3, or just positive and negative?
So thank you for your question. So as per the CAP guidelines, we do 0, 1, 2, 3, not positive, negative anymore, yeah? And that's because of the treatment implications that it has for the patient moving forward.
Okay, thank you very much. I think we are supposed to have yes, there's one more question there.
Okay, again, I have a question to Dr. Priscilla regarding the use of control, the tissue control for HER2. Can we use maybe the control from the breast cancer initially, which has been put, because you have suggested that control may be the uterine cervix or the tonsil tissue. So can we use a previous breast cancer positive HER2 as a control to a case with a breast cancer for HER2? Or you must use the uterine cervix as you have suggested?
No, so we use breast cancer control, yeah? And actually the ideal is to have a control that shows the spectrum, because remember HER2 is heterogeneous, so there's some areas that should be 3+, some areas equivocal, some areas 1+, but ideally you should use a breast cancer control.
Okay, thank you.
And for the uterine cervix, it's more for the ER, yes, not for HER2. Yeah. Okay. Great. So I think we have about just under an hour for your lunch break. Lunch will be served at the same place. Thank you very much, Anne and Amelia. That was excellent. So we can move down for lunch and reconvene at 1:30. Thank you. Thank you.
Thank you.